righty. So case number 12. At what point in hysterectomy can the ureter be most commonly injured?
At the point where you're making the colpotomy.
Anywhere else?
You can also injure the ureter at the time that you are suturing the vaginal cuff.
Anything else?
Those are the most common places.
So what has a greater, go ahead.
I was going to also say, like, when you take the uterine arteries as well, when you ligate the uterine arteries, you can also injure the ureter at that point.
Can you tell me the course of the ureter for me?
Yes, the ureter exits the renal pelvis and will then travel over the psoas muscle. And then we'll travel over the bifurcation of the common iliacs, and then we'll travel medially against the, or medially to the ovarian, medially to the, oh my gosh, medially to the ovarian pedicle, and then we'll continue to travel, and we'll go underneath the uterine artery into the bladder.
Now, you did this as an LAVH. Why did you decide that route of hysterectomy?
This route of hysterectomy was discussed with the patient because of her history of hydrosalpinx. It was discussed with her to in regards, oh gosh, it was discussed with her to proceed with this type of hysterectomy because she had a history of a hydrosalpinx, and the previous and the ultrasound prior to her surgery suggested a hydrosalpinx in order for appropriate visualization of any adnexal pathology.
So let me ask you this: how large was the hydrosalpinx?
The hydrosalpinx was approximately 2 to 3 centimeters in width, if I can remember correctly.
And what did you say recurrent?
This patient had previously had a hydrosalpinx on a previous ultrasound that was noted.
So how the hydrosalpinx resolved?
To my knowledge, the hydrosalpinx resolved with observation.
What time frame observation?
I am not 100% sure, as this patient was taken care of by a previous provider.
What do you mean previous provider? You mean she was a transfer of care to your practice?
Yes.
So you said the hydrosalpinx was 2 to 3 centimeters.
Mm-hmm.
I mean, is that big enough to affect if you did the procedure vaginally, if you had done a TVH?
No.
So could you have done a TVH?
Yes.
So why didn't you?
So can I ask a question about these? Because these are residency cases. So if the attending does a certain case one way, how is the best way to defend that?
You would have to say, I mean, they're your cases. So in essence, you've taken ownership, but if something very blatant, then you have to say the attending surgeon wanted to do it this way.
Okay.
But keep looking at your this case.
Okay.
Would a TVH would have been amenable? Yes or no?
Yes, it would have been amenable.
Are you sure?
Yes.
Can you, so in this case, did you do anything in order to suspend the vaginal vault to prevent vault prolapse in the future?
We incorporated the uterosacral ligaments into the vaginal cuff.
How'd you do that? More specifically?
In this case, we closed the vaginal cuff from below. And so in doing that, we used an Alice clamp to secure the vaginal, to make sure that we were appropriately grabbing the uterosacral ligament. And then grabbed that and then incorporated it into the cuff.
Are there other prophylactic procedures that could be performed to prevent future vault prolapse?
Yes, you could do a McCall suspension or a true uterosacral ligament suspension.
So can you explain to me how you do a McCall?
Yes, with a McCall's suspension, you would grab or use an Alice clamp to grab the uterosacral ligament, and then would, using Vicryl suture, you would plicate it or do stitches through the uterosacral ligament, and then I'm blanking on the remainder of this. I would have to look up the remainder of this.
So let me ask you this: when you do a McCall procedure, how
Mhm.
do the uterosacrals plicate?
You placate in the center.
So can you dictate for me a vaginal hysterectomy? The patient's prepped and draped in a normal sterile fashion. You're ready to start your incision. Timeout's already done. You're ready to start the case.
Yes. So a vaginal hysterectomy, I would start with placing a weighted speculum into the cervix or into the vagina, and then grab the cervix with a tenaculum. I utilize lidocaine with epinephrine to inject into the cervix in order to help me circumferentially incise the cervix and dissect the bladder off the pubovesical cervical fascia. I then will proceed with entering into the posterior cul-de-sac with Mayo scissors. Once I'm able to identify the posterior peritoneum, I will grab that with I will secure that with a 0 Vicryl stitch, and then I will return up to the anterior anterior part of the cervix in order to enter the anterior part of the case. I make sure that my bladder is correctly identified and off the pubovesical area. And then I will identify my uterosacral ligaments on each side with Haney clamps. I'll place my Haney clamps, transect those, and then tie off using 0 Vicryl suture. I will then proceed more proximal to the side of the uterus on the cardinal ligaments, and then I will clamp, cut, and tie those with 0 Vicryl bilaterally. I will then proceed to go up to the uterine arteries, and I will clamp, cut, and tie those with 0 Vicryl.
Let me interrupt here a second. So you get the uterosacrals first, right?
Correct.
What comes after the uterosacral?
After the uterosacrals will come the uterine arteries.
Followed by?
Followed by the uterine ovarian pedicle.
Let's say you have difficulty entering anteriorly. What would you do?
If I had difficulty entering anteriorly, I would enter posteriorly first,
And then do what?
and then clamp and cut my uterosacral ligaments, and hoping to provide myself a little some more visualization, so that I could enter anteriorly better.
All right, let's stop there. What'd you think?
It was not great.
So, I mean, you're an MFM.
Yeah.
I think you did pretty decent. Okay, at what point in hysterectomy, most commonly, could the ureter be injured? At the IPs, the uterine arteries, the uterosacral ligaments, cuff angles.
Okay.
Make sense?
Yeah.
For those on the call, ureteral pathway. The ureter runs along the anterior surface of the psoas muscle to the pelvic brim. The ureter enters the pelvis at the bifurcation of the common iliac artery. It descends retroperitoneally on the lateral pelvic wall and runs posterior to the ovary. As it descends through the pelvis, its course becomes more medial. It is identified on the medial leaf of the broad ligament. It passes under the uterine artery, water under the bridge, and into the paracervical tissue, into the tunnel of the cardinal ligament anterior bladder pillar, or the tunnel of Wortham. The ureter is located 1 to 2 centimeters lateral to the cervix and uterosacral ligaments. It courses immediately over the anterior vaginal fornix to enter the trigone in the posterior aspect of the bladder, and travels anterior medially to enter the trigone. In regards to the McCall procedure, so for prophylactic, you have the McCall, you have the uterosacral ligament suspension. For treatment, it's the SSF, the sacrospinous ligament fixation, the sacrocolpopexy, and the uterosacral ligament suspension. So with the McCall, you're at your angle of the vagina. You go through the angle. You grab the uterosacral ligament, pass the suture through there. I think you should do more of a delayed absorbed suture, not a permanent, but delayed absorbed.
Okay.
Put it through the uterosacral, reef the suture through the posterior peritoneum, go out on the other uterosacral, the other cuff angle, tag it. Now you're beyond the vagina, you move up. You get the uterosacral, reef it through the posterior peritoneum, go out the uterosacral, tag it, and you could do it a third time.
Okay.
Okay. In regards to the TVH, you're going backwards. So you get the uterosacrals first, followed by, like you said, the uterines. But when you dictated it, you said you were getting the cardinals. You say more the cardinals as you're going up. You kind of hit the uterines kind of first. And then go up the cardinal, keep going up, keep going bite to bite to bite on side to side to side to get to the uterovarian.
Okay.
Now, a 2 to 3 centimeter hydrosalpinx, you should still be able to see them, but I wanted to see what you would tell me. So I try to psych you out. But the reason I would do an LVH in this case is because of your first diagnosis, pelvic pain. And that you can't assess with a, without your scope.
Okay.
Right?
Yeah.
So that's why. So I just started asking about the hydrosalpinx. Realistically, to my understanding, I'm not an expert, but if you have a hydrosalpinx, it usually sticks around. It doesn't disappear. I could be wrong, but usually it stays, doesn't it? There's fluid that got collected there.
Yeah.
It could be a chronic pyosalpinx, It could be a hematosalpinx. Those usually don't disappear, usually cause pain, and they end up going to the operating room. But you got to defend why a small uterus, LAVH is a good choice, don't get me wrong, especially in this situation with the pelvic pain. But anything that's small, you have to defend why you didn't do it vaginal. They're trying to ding you, right? So you got to be well versed. Make sense?
Okay. Yeah, no.
Other questions?
I don't think so. I think, some of my main questions are, obviously I wasn't the decision maker in, senior residency cases, and how best to defend
Right. If
That's
it's something really like they're really hitting you hard and you don't know how to get out of it, but in the end, you have ownership
mm-hmm.
of these cases, unless it's something so grossly wrong.
Right.
I'm trying to think. I did a mock oral and it was for senior, and she had senior residency cases and she had 2 cases. I'm like, I don't even know what you did here. And she actually had to say it was my attending because it was not standard of care.
Okay.
If it's not standard of care, you got to have you're going to have to go to that option. I think you went too soon in this case. Am I making sense?
Yeah.
Okay.
Thank you.
But that could happen. But in the end, it is your case.
Mm-hmm.
You know, so you have to defend it tooth and nail, unless it's something so gross. You know.
Yeah.
Okay.
Okay. Thank you.
All right. Yeah. No worries. So is Erlene on the call? I do not see her. Oh, I see somebody has a question. I'll go there in a second. Trying to see if I see Erlene here. No, I don't see Erlene. Jewel, I'm gonna see if you're here. Jewel, I don't see Jewel here either. Idioma, I think I did see you. You're here. Are you there, Idioma?
Yes, I'm here. I'm on
Oh,
call.
I'm sorry, say again.
I said I'm here, but I'm on call waiting for
You're on call?
delivery. Yeah.
So do you want to take it to the flip side and just put your hand up if you do the delivery? I don't want to rush you if you
Okay.
get called out, okay?
Okay.
And then you'll get a shot at a different time if you don't do it today, okay? Not a problem. But just rate, put something in the question box or raise your hand if you're done with the delivery, okay?
Okay. Okay. Thank you.
All right. So I have Victoria saying the list is visible. Okay, cool. I can see the list. Awesome. Hydrosalpinx does not generally resolve. It will be visible. It will be visible for a long time due to clogged tube. So Victoria kind of sided with what I was saying. How do you recommend we address why didn't you do this as a vag his question? We have none on our case list and we haven't done any in general OBGYN practice. I've had people explain they don't feel comfortable doing them. This is not how they trained in residency, but there's nothing wrong ever saying, but I'm willing to learn. Luckily, hopefully you have a mentor that's older that is willing to assist you in learning the technique. Sometimes easier said than done. But to say, you can say, I don't feel comfortable, but I'm willing to learn, right? So does that make sense, Caroline? You can't just say, well, this is the way I do it. You got to always say, I'm willing to learn a different technique. Okay, so hopefully that makes sense, Caroline. I'm going to Tiffany. Hopefully Tiffany's on the call. I see Tiffany here. Are you there, Tiffany?
Yep. Hey, I thought I had a little bit more time before
Well, the 4 people ahead of you couldn't go. So there we are for 92.
Okie dokes.
See it?
Yep.
Is it there?
Mm-hmm.
You see it? Case number 92?
I see it.
All right, cool. Can you discuss for me how you evaluated the patient to see if she was a candidate for a TOLAC?
So typically when I am establishing or deciding if a patient is a candidate for a TOLAC, initially I would do a history and physical with the patient and kind of get more information of their previous obstetrical history in terms of when they had their C-section and like the gestational age, the type of incision, the uterine incision that they did on the patient. I would also assess kind of the reason why they had their initial C-section. Those are usually the initial things that I do when I'm considering if a patient is eligible for a TOLAC. Of course, also if they have any any reasons that they couldn't have a vaginal delivery, that would also kind of take them out of that picture. In my practice, I will say though, even though I know that you are eligible to have a trial of labor after C-section with 2 prior C-sections, we do not offer TOLACs to patients who've had 2 prior C-sections.
Why is that in your practice?
I think it's just some of like the hospital guidelines that they have enacted on us. And that's really the reason why we don't offer them.
So does the patient have a higher risk of rupture because she's had 2 prior C-sections?
No.
So why does your hospital not allow
I think
a
it's
TOLAC?
just given I mean, I'm trying to think of how to say this. I think it's just given the fact that the patient has a higher risk
Charging battery.
like postpartum hemorrhage and other kind of surgical complications, that they rather not take the risk.
So you're telling me this patient at your hospital was not offered a TOLAC because of the concern for increase in postpartum hemorrhage, yet she had a postpartum hemorrhage in a C-section that was a repeat.
Yes, unfortunately, just having the history of a C-section does increase your risk of a postpartum hemorrhage. But I think it's given I think ultimately the concern is that if you do have a prior C-section and you're trying for a vaginal delivery, and the biggest risk you're concerned about is a uterine rupture and the need to have an emergent surgery with the history of 2 prior C-sections, I think was the concern.
So what are signs of uterine rupture?
Some of the signs you can have of uterine rupture could be abnormal fetal heart tones. You could also sometimes see a loss of fetal station. You can see an excessive amount of pain or in the patient, or like pain that kind of outweighs what you would typically expect. Those are usually the initial kind of signs you can see of uterine rupture.
So what's the risk of uterine rupture with a low segment transverse prior LST?
Less than 1%.
And what about classical?
And that can increase up to 10%.
So what increase your risk for uterine atony?
Some of the things that can increase risk of uterine atony are prolonged exposure to Pitocin. You could have if you have like a very large baby, or polyhydramnios, if you have multiple gestation, if you have a history of postpartum hemorrhage, if you had a very long second stage of labor, are some of the things that can increase your risk of uterine atony.
And what's the definition of postpartum hemorrhage?
Postpartum hemorrhage is if you lose more than 1,000 milliliters over 24 hours, or if you have blood loss with vital sign abnormalities.
So can you tell me the different uterotonics that are available, the name of the medication, dosing, route of administration, frequency, any contraindications?
Okay. So first I would start off with Metrogen, which is a I forgot how to, it is a type of medication that you would give
I asked for the name of the medicine, the dosing, route of administration, frequency, and any, I don't care what type of drug it is.
Okay.
You see where I'm coming from?
I get you. Okay.
Mhm.
Some of the medications that we can give, you can give Pitocin. That would be a medicine that you can give either IM or IV. You can give 10 units IM, and the name of the medication, the dosage, route of administration.
And any
And
contraindication.
contraindication would be a prior hypersensitivity to Pitocin. In terms of another one would be Hemabate, which is a prostaglandin. You would give that IM, that's 0.25 micrograms. You can give that Q 15 minutes, a total of 8 times. And a contraindication for that would be like severe asthma. You can also give Metrogen, which is 0.2 milligrams subcutaneously, and that would be the contraindication that would be like severe hypertension or hypertension.
Any other medication.
There's also TXA, which I believe is, I think, 1 gram. And contraindications for that, I believe it's like if you have like an active like thrombus or VTE. And there's also
Any-
side. Go
Okay.
ahead.
Go ahead.
And there's also Cytotec, which you can give 1,000 micrograms rectally. And I think a contraindication to that would be, I believe, if there's like severe like lung disease. Or
How many times can you repeat it?
the Cytotec?
Yes.
I believe that one I would have to look up to know for sure. I think the max you can give is 2,400 micrograms, but I don't know how often you can give 1,000 micrograms at a time.
So how did the left uterine artery laceration occur?
For this patient, I believe the left uterine artery laceration occurred as we were delivering the baby. And I believe there was an extension that was towards that left side during the
So discuss for me specifically how you performed that left uterine artery ligation.
Okay, so what I did was, after kind of assessing the situation and seeing where the bleeding was going, I got my stitch and I placed it 2 centimeters below the hysterotomy, going from medial to lateral, and trying to go around that uterine artery. And then I did kind of like a figure of 8 stitch around that inferior aspect of the hysterotomy, and then I went 2 centimeters above the hysterotomy, same on the left side, and repeated that same thing.
So you did it twice, above and below.
Did do it above and below.
Why above and below?
Because initially when I did it below, I didn't feel that I had complete control of the bleeding, and I wanted to decrease that like the pulse pressure with the uterine artery. So I went above and below.
Okay, let's stop there. What'd you think?
There's some improvements that could be had.
So answer the question they're asking. Don't add more information.
Yeah, especially if
Make
you can't
sense?
your head. Yeah.
But that's when practice comes into play. In regards to the C-section ×2, I mean, ACOG says that you're allowed, and you did say that, but they said at my facility. So then I just started to be sassy and say, okay, but why would that be the case? And then you said, well, you have a greater risk of postpartum hemorrhage. And I think the greater point would be if she tolacks and fails, that's the more difficult procedure. Does that make sense?
Yeah.
So then you could get, but to say from the, from the get-go, yeah, you're greater risk of postpartum hemorrhage. Yeah, you did a C-section on her and you got a postpartum hemorrhage. So kind of that, you know what I'm saying?
Definitely.
Yeah. So you're correct. It is a less than 1% risk with the LST. It's actually 0.5%, 10% with the classical incision. The risk of uterine rupture. Contraindications to a VBAC, a C-section time, more than 2 C-sections, a classical, any, myometrial surgery, like a myomectomy, not a hysteroscopic, okay, not a hysteroscopic. And any contraindication to a vaginal delivery, such as a previa. Don't go any further than discussing anything else, everybody on the call. People are saying malpresentation, the patient has HIV. They're gonna, if you bring that up, they're gonna ask you about it. So nobody's gonna deliver a patient vaginally that has a previa. Some people do malpresentations. They can ask you about face presentations, brow, so on and so forth. So nobody's going to deliver a patient that has a previa vaginally. Also, you do not have the capability of doing a stat C-section. You don't have people in the house and so on and so forth. Okay. Signs of uterine rupture, vaginal bleeding, loss of station, non-reassuring fetal heart tracing, lower abdominal pain. Okay. In regards to PPH, it's a cumulative blood loss greater than or equal to a liter, or a blood loss accompanied by signs and symptoms of hypovolemia within 24 hours after the birth process, regardless of mode of delivery. So Methergin is 0.2 milligrams IM. It's an Ergovat. I'm sure I'm saying it wrong myself. Q every 2 to 4 hours. Contraindication, hypertension. Hemabate is 0.25 milligrams or 250 micrograms IM. You were correct with everything else you said. Misoprostol is 1,000 micrograms per rectum or 600 micrograms sublingual times 1 dose without any contraindication. Tranexamic acid is 1 gram IV. If initial medical therapy fails, it works best if used within 3 hours of delivery. I guess if you had an active VTE, but I know in the trauma literature, not that I'm an expert, you don't say literature, if somebody's bleeding out, you're going to give it to them regardless what happens, right?
Mm.
Okay. I thought your explanation of the left uterine artery was nice. That's the reason I asked you about this question, but I asked you other things before we got to that. So questions?
No, this was good. I need to learn to not give extra information. No, I'm gonna practice on that.
Right. Unless you're really good at that extra information.
Unless I know what I'm gonna say.
Exactly. If not, don't say nothing.
Mm-hmm.
Because you shoot yourself in the foot.
Yep.
And you don't want that. Other questions? Great job.
Thanks.
All right. Chibi, I'm going in your direction. And I'm going to see if anybody, while I put you on the call, see if anybody has any questions in the question box. I see some questions. It says you are self-muted, Chibi.
Hello?
Yep, you're there?
Yes.
Awesome. All right. Generalist?
Yes, I am.
Okay. Are you okay if we do office?
Sure.
All right. I have a couple of questions here. So somebody, Chikara said for TXA, it's only conjured if it's active, not prior history. I'm gonna be honest with you. If somebody's hemorrhaging, you do whatever you can, to give the TXA. To be honest with you, it's different if you're doing it for like somebody who has abnormal uterine bleeding. That's a different setup. But this lady's hemorrhaging, you got to do something. Okay. there's an increased risk of rupture with history of C-section times 2 correct in comparison to 1, up to 3%. I believe what you're mentioning there, Jennifer, and I could be wrong, this might be an MFM question here. I believe the 3% is a low vertical. If you have 2 C-sections, I think the most it could increase it is 0.8, but I am not an expert. So is Corinne still on the call? As an MFM fellow. It says you're self-muted, Corinne. What do you have to say there, Corinne? Am I off?
Yeah, there is the data isn't as great for 1, but there is a slightly higher risk of uterine rupture. It's like 1.5 to 2.5.
1.5. Really? Okay, I thought it was 0.8. Because I know the low vertical is 3%.
Yeah, so like a history of 1 previous cesarean section is somewhere between 0.5 to 0.9, depending on what literature you look at.
Okay.
I think it all depends on the literature that you
You're
look at,
looking
and what you want to quote, which you shouldn't do in this exam. But
You got it.
I think you can say
yeah.
that there is an increased risk. It's less than a classical and less than a low vertical, but
Because low vertical is 3%, correct?
correct.
Okay. And Bobby says between 1 and 2%. That's kind of high. Interesting. I thought it was 0.8, so my apologies. All righty, well, thank you, Corinne. Okay, Chibi, you're there? I think I got all questions answered at this point. Are you still there, Chibi? Case number 6. Discuss for me how you diagnose premenstrual dysmorphic disorder.
So this was a patient who came to me with symptoms that were altering her activities of daily life that were coinciding with her menstrual cycle. She reported that she'd been experiencing these symptoms for several years. And so I talked to her about whether or not, her work life was affected. She, I think, was enrolled in a graduate school program and also mentioned that she was not able to attend classes because of the pain associated with her menses. So we talked a bit about how she met the criteria for PM or premenstrual dysmorphic disorder, and how to manage that. I spoke to her about contraceptive options, and she ultimately decided to proceed with a trial of an SSRI along with an OCP.
Would it have been okay just to give her the OCP alone?
It would have. She actually came to me with already on a combined pill, and so the SSRI is what we added to her current regimen.
So specifically to diagnose the PMDD, what specifically has to be present?
So it has to be, a patient has to report symptoms that or clinical symptoms that are timed with their cycle, that last at least.
When you mean clinical symptoms, specifically what clinical symptoms?
So mood lability, so behavioral or emotional symptoms of mood lability, decreased sleep, irritability, loss of interest in activities that are usually of interest to them. There are also some patients that report some physical symptoms prior to their menstrual cycle, and for example, headaches.
Anything else that specifically needs to be present in order to meet diagnosis?
I believe just that the symptoms need to be timed with their menstrual cycle.
Okay. Now, what is the difference between the PMDD and PMS?
So I believe PMS is similar symptoms, but the quantity of symptoms is less. I don't recall the actual number, but it tends to be lesser occurrences that, in terms of behavioral or emotional symptoms, that do go away with their cycle.
Now, how did you instruct the patient to take the SSRI?
She actually asked, well, I instructed her to take it continually, as in daily, but she actually asked if she could take it cyclically with her menses, and I believe she elected to do that, but my initial recommendation was to take it throughout the month.
So can you describe a little bit more detail what you mean by cyclically?
She asked if she could start it because her cycles are predictable and she was already on an OCP. If the last week during her withdrawal bleed of her OCP, if she could start the SSRI that last week.
And for how long does she take it?
For those 7 days of either the inactive pill or the, I believe it was an inactive pill that she had, not a.
So she just takes it for 7 days.
Yes, if she were using a cyclic method.
And any other medication you could offer? Or any other treatment option discussion? Let me put it that way. As well.
So I did not include that in my case list, but we could have also considered therapy or psychotherapy for her. That'd be another non-medical option for her.
Anything else?
Not that I recall at the moment.
Okay. So you have here contraceptive counseling. Can you describe for me how you counsel in general a patient in regards to her contraceptive options?
So I'll often try to ascertain what length of time my patient is wanting contraception. And that way I can tailor the discussion just a bit, but we'll also go through their medical history and see what there may be contraindications to different therapies. For example, estrogen containing therapies. I typically discuss combined oral contraceptive pills, how they're prescribed, what their common side effects are. I'll then also discuss long-acting reversible forms of contraception. I'll also go over other methods to include the patch or ring or depot injection forms of hormones as well.
So what's the mechanism of action of Depo-Provera?
So Depo-Provera is an progesterone or progestin therapy option. It is a long-acting form in that it's an injection that's given intramuscularly that lasts for 3 months. Its method is suppression of ovulation via progesterone.
Specifically doing what?
It's suppressing ovulation.
How does it do that?
Oh, oh gosh. Thinking.
So you had said the Depo, the ring, the patch, correct?
Correct.
Anything else you could offer the patient?
They're the ring, the patch, the long-acting reversible forms of contraception, to include the implant, the progestin-only implant, and then the progestin IUD, as well as the non-hormonal Paragard or copper IUD.
Anything else you could offer the patient in regards to, in general, contraceptive counseling?
She could also consider the use of barrier methods.
Anything else?
That's all I can recall at the moment.
So what's the mechanism of action of the progestin implant? Did I lose you? Are you still there? Hello? Hello? Chibi? Did we lose you? Hello, Chibi? Well, guys, at this point, I think we've lost her. So let me go over it. So premenstrual dysphoric syndrome, at least 5 of the following with at least one core symptom present a week before the period, and it remits a few days after the onset of the period. Core would be mood swings, depressed mood, sudden sadness, increased sensitivity to rejection, anxiety, irritability, sense of hopelessness, self-critical thoughts, tension, feeling on edge. 5 of the following. So that was the core. And then you could have 5 of the following: difficulty concentrating, change in appetite, overeating, diminished interest in usual activities, decreased energy, feeling out of control, breast tenderness, bloating, headache, joint muscle pain, weight gain, changes in sleep, symptoms interferes with life. That's the difference between PMS and PMDD. Okay? PMS is kind of mild to moderate with no functional impairment. Treatment: stress reduction, change in diet and exercise, SSRIs. This is what the patient was started on. Anxiolytic, you could do buspirone, 5 milligrams BID during the luteal phase. OCPs, I thought you would do it more for 2 weeks. I can't comment on taking it just that 1 week. But I've always thought it would be the 2 weeks of the luteal phase. So I can't comment on that. In regards to birth control, do not forget, I said general, do not forget about permanent sterilization, male and female. To my understanding, Depo-Provera, the way it works is it prevents the LH surge, therefore it prevents ovulation. The Nexplanon as well, the main mechanism of action, it prevents that LH surge, prevents ovulation. However, on the 3rd year of it being in place, you could ovulate. So therefore, the cervical thickness, the environment of the endometrium being not conducive come into play. So hopefully that makes sense. Okay. It's dysphoric, Rosa. Oh, it says dysmorphic. Oh, that's a good point. Chibi, I hope you can hear us. It says dysmorphic. Yes, there you are. What is vaginismus?
Vaginismus is it's when you have I'm sorry, I'm blanking out. It's the inability to tolerate any vaginal penetration, and it can be generalized and localized.
So how do you diagnose it in a patient?
So in a patient presenting with such complaints, when I do a physical exam, I'll look for any specific trigger points where I can elicit pain on my exam. At the same time, I'll also look for any signs of, for example, if she is in the postmenopausal age group, then I'll look for signs of any signs of GSM or genital symptoms, urinary of
Let me
GSM.
interrupt you here for a second.
Yeah.
Let me interrupt you here for a second.
Okay.
So when you're telling me if she was postmenopausal and you're saying genital urinary
Symptoms, yeah.
symptoms, is that vaginismus or is that dyspareunia?
Vaginismus can also present with dyspareunia.
So what's the difference?
I'm sorry, I'm blanking out right now. Yeah.
We're going to go slow here. So when you examine a patient
Mm-hmm.
and you believe she has vaginismus, let me ask you this, like, how does she present to you with her symptoms? What would she tell you?
She would present with pain with like any vaginal intercourse.
So any penetration.
Any penetration, yes.
Okay, so what's the difference between that and dyspareunia? What's the definition of dyspareunia?
Dyspareunia is painful intercourse. It could be superficial or it could be deep dyspareunia.
But for the most part, you can have relations.
Oh, yes. Okay.
It's just painful relations.
Okay.
Vaginismus, can she really have relations?
With vaginismus, most likely
She'll have
not.
dyspareunia,
Yeah.
but it might be tough. So what happens when you have vaginismus? Why does that happen?
It can be because of the pelvic floor dysfunction or contraction of the pelvic floor muscles.
Exactly.
Which can, yes.
Do you have that with regular dyspareunia, let's say for atrophic vaginitis?
No.
Okay, so vaginismus is a different entity, correct?
Yes.
Okay, so when you examine this patient, what supported that diagnosis?
So an exam, I'll be able to elicit tenderness on any kind of, on any touch or just like examination, I'll be able to elicit tenderness.
Tenderness, or would she get
Or
involuntary contractions? from the pelvic-
involuntary muscle spasms.
Exactly. Do you know any of the subcategories of vaginismus?
No, I'm sorry. I'll have to review that.
Okay, so how did you counsel the patient in regards to this diagnosis and how you discussed the treatment options that are available?
So for this patient, I talked to her about like sequential using vaginal dilators, using lubrication, using vaginal moisturizers, and even pharmacological therapy like I think it was vaginal, placing a vaginal diazepam.
And
Also,
go ahead.
And also, we talked about pelvic floor exercises. In fact, I sent her for pelvic floor therapy as well.
Now, was that beneficial for her? What did they do there in the pelvic floor physical therapy?
Well, with pelvic floor physical therapy, she had when she was taught certain pelvic floor muscle exercises, and she was taught about relaxation techniques for the pelvic floor contractions, and she also got biofeedback, and then she had a total of I think six sessions, and following which she had some marginal improvement.
So what does the dilation therapy do for the patient?
Um, so if at all there is, so the sequential dilation will help with the
What specifically is the purpose of it? Does it enlarge the opening? Does it desensitize the patient? What does it do?
it could cause sequential dilation of the vaginal introitus. I believe that's how it works.
Okay, let's stop there. A little bit tough, huh? First time on the hot seat, right?
Yeah.
You kind of forget everything, right?
Yeah, I will have to review the vaginismus.
We're going to go over it right now. But don't make the error of bringing in other things that have nothing to do with what they're asking you, because
Right, right.
you're kind of desperate. You're like, okay, so now you start talking about, oh, she's postmenopausal. Then you start
Yeah.
bringing in the atrophic vaginitis. She has dyspareunia. That's two different things. Now, I'm not saying she doesn't have dyspareunia, but the vaginismus is giving her dyspareunia for a different thing versus atrophic vaginitis in a patient who's postmenopausal.
Mm-hmm.
Okay, so be careful,
Yeah.
because it pounce on you and eat you alive on that one. So vaginismus is traditionally referred to involuntary contraction of the muscles of the pelvic floor surrounding the vaginal orifice. The patient is adverse to vaginal penetration, sexual, non-sexual, like GYN exam, tampon, dilators. Subcategories, this is as per up to date, because I am not an expert in this at all. Primary is lifelong pain with attempted vaginal penetration. Secondary is progression to painful vaginal penetration after some pain-free period. Situational, inability to tolerate certain forms of penetration, yet insertion of tampons or fingers is possible. Spasmodic, spasm of the vagina, or complete inability to tolerate any vaginal penetration. Now, dilator therapy, vaginal dilator therapy, desensitizes. That's the goal of it. It doesn't enlarge the opening. It does not cause enlargement of the vaginal opening. You need to use a small amount of topical anesthetic so the patient can start getting desensitized. You were correct with the other treatments that are out there. Sex therapy, progress relaxation, sensation focus, biofeedback, use of benzodiazepines, hypnotherapy, and worst case scenario, Botox. Now, a patient that is situational, perhaps some therapy would assist in that, because it's the situation. If somebody got assaulted, for example, it might be very difficult for them to have relations because of PSD, so on and so forth. Okay. So questions?
No, I'll just have to review it better. Yeah.
It is your third case.
It
So
is mine. Yeah, it is my third
it's
case.
a good case. It's a good case. And if you
yes,
review
but
this, it's an easy, you did everything correct for her.
Yeah, I
You
just
said
have
it right
to
here,
verbalize
unable
it.
to tolerate vaginal. And in doubt, look at your list. What did I do for this patient? Let me look.
I did, yes.
Yeah, you have it all right there written. So,
Oh, that's true, yes.
all righty. Other questions?
Okay. No, I'm good on this one. Thank you.
All right, very good. All right, so we're going to be going. So, case number 15.
Okay.
So, let's say your pathology came back as a partial mole.
Okay.
How would you manage the patient?
So if my pathology came back as a partial mole, then I would obviously review the results with her and talk about the possible implications of what a partial molar pregnancy entails and what it means. And then I would discuss with her trending her beta HCG values to make sure they go down to 0 and stay down at 0. And the potential risk of developing into gestational trophoblastic disease.
So let me ask you this. How does a partial mole occur?
So a partial mole will be, the karyotype will be a triploid. So either 69XXX or 69XXY. And it will have some fetal parts that are evident on the ultrasound findings. And it is, yes.
And so what is risk of partial mole leading to DPN?
So the risk is pretty low. It's about 2%.
And let's say it was a complete mole.
The risk for a complete mole would be about 15 to 20%.
Discuss specifically how you would follow the patient postoperatively.
So with a partial mole, I would follow her HCG weekly until it is negative, then monthly for 3 negative values.
So for
Or
3 months?
Yeah, for 3 months.
Anything else you would recommend to the patient?
I would recommend that she stay on birth control during that period of follow-up, so she doesn't get pregnant, because if she did, then it would create a conflicting picture.
So let's say it was a complete mole. Would that change your follow-up?
It would, yes. I would follow her weekly until she had 3 consecutive negative values, and then monthly for 6 months.
Now, can you give me any circumstances specific where you would be concerned as you're monitoring this patient that GTN could be present?
If her beta HCG were to plateau or increase during that follow-up period, or if there were to be, if her pathology were to come back concerning for it, but that would have been evident earlier. So mostly if her beta HCG were to plateau or increase, or if she were to have
So
persistent.
plateau over what time frame?
So if she were to have a beta HCG that was 3 values that didn't decrease by 15% over a period of 4 weeks.
Any other clinical scenario?
If her beta HCG were to be positive at 6 months, we talked about it increasing over 3 values that increased over a period of 2 weeks. And then if she were to have any other like clinical signs or symptoms that were to be concerning for it. So if she were to represent with vaginal bleeding, or if for any reason we did imaging that was concerning.
So let me interject here a second. So let's say the patient's HCG is negative,
Mm-hmm.
and then she has vaginal bleeding. You'd be concerned, or only if the HCG was elevated? I didn't quite understand what you were talking about.
If the HCG was elevated.
Does it matter how elevated?
No.
So it could be a beta HCG of 10.
Correct.
What histologic types comprise GTN?
So you could have a placental, the placental tumor. You could have gestational trophoblastic neoplasia is kind of like the overarching title for all the different subcategories, which could include choriocarcinoma. I'm blanking on like the name for the placental site tumor, but
Can you tell me what the WHO prognostic factor scoring system tells you?
so the WHO prognostic scoring factor system will tell us if someone is at high high risk or low risk and based off of that, if they would need multi-agent chemotherapy or single agent chemotherapy.
And what is single agent?
Methotrexate or actinomycin D.
Now, let's say you have a patient who has a partial mole. You knew ahead of time that it was a partial mole, or you can make it even complete mole.
Okay.
Not that you already got the pathology. You knew. How would you diagnose a molar pregnancy? Let's say a complete mole to make it easy.
So if I had an ultrasound that was concerning for a complete mole, I would, or clinical findings. So if she was size greater than dates, if she had a very high beta HCG value, oftentimes was accompanied by hyperemesis. And then they can also have fecality cysts on their ultrasound findings. And then typically there will be no fetal parts on the ultrasound and a snowstorm appearance of the tissue.
Anything else that would sway you towards complete mole?
And then if the karyotype was 46XX or 46XY.
Anything else? Any laboratory value?
If the beta HCG, if the was greater than 100,000.
Now, what treatment options would you discuss with that patient?
So I would discuss with the patient that the recommendation is for evacuation, and that could include a D&C. If she didn't desire the pregnancy and was done with childbearing, a hysterectomy would also be appropriate.
What would be appropriate? I'm sorry, you broke up.
A hysterectomy.
Okay, we're gonna stop there. What do you think?
It's much harder when it's like you read the study
You're on the
materials.
hot seat, right? Yep.
Yeah.
No, but I thought you did well. So I just changed the story.
Yeah.
Because I already had asked somebody about hysterectomy and stuff like that. So I'm like, let me grab something else.
Yeah.
So partial mole is a normal ovum fertilized by 2 sperm or occasionally a diploid sperm. Correct?
Yes,
Triple E,
I was
69
blanking
triple
on
X, 69XXY. Partial mole GTN is 5%. Complete mole is 15 to 20%. The practice bulletin for molar pregnancy has been pulled. It has not been replaced. So we don't have any guidance, but according to UpToDate, and I believe the oncology journal, whatever it is, I don't know, I'm not an oncologist, they came out with like a article review, and the recommendation is to follow HCGs weekly until normal for 3 weeks, then monthly times 1 for partial mole, times 3 months for a complete mole. Okay, but there's nothing wrong in saying when I trained, it was 6 months. It didn't matter what type of molar pregnancy.
Yeah, I think this one has always been a question that I've had because I haven't been able to get like a definitive answer over what the
We don't,
follow-up is.
ACOG ain't guiding us because there's no practice bulletin. I checked maybe a month ago, 6 weeks ago, and it
Okay.
hadn't come out. I'm not saying it's coming out, just like, it's interesting. That's kind of an important topic, but here we are.
Right.
So don't forget about birth control. If she gets pregnant, it's going to throw everything off. Histologic types that comprise GTN: invasive mole, choriocarcinoma, placental site trophoblastic tumor, epithelioid trophoblastic tumor. So here is 2 scenarios where you'd be concerned about postmolar GTN. Increasing HCG greater than 10% across 3 values over a 2-week period. Plateauing HCG, or measurements that remain within plus or minus 10% over at least a 3-week period. Ectopics is 15%, molar pregnancy is 10%. Okay, that's the way I remember it. Okay.
Yes, after I said 15%, I was like, that's not right.
Your prognostic scoring system: age when the patient's diagnosed, what type of antecedent pregnancy was it, time from index pregnancy to when this occurred, pre-treatment HCG, sites of metastasis, number of metastases, all that's factored in. A score less than depending who you read, 6 to 7 tells you it's a low risk GTN treatment. So again, like you said, single agent, either methotrexate or actinomycin D. Okay, you're correct. If the patient's done childbearing, the recommendation is to do a hysterectomy. Okay, did I miss anything?
Thank you.
Sounds good. Case number 4. Can you discuss for me how you handle a shoulder distortion?
Yeah, so when I am in the delivery room and I feel that there's a shoulder dystocia, meaning that with gentle traction, downward traction on the head, the shoulder is not, the anterior shoulder doesn't deliver. I tell the mother to stop pushing. I call for help, and I notify the nurses and everyone in the room. I have them bring step-ups into the room. I perform suprapubic pressure typically towards the on the anterior shoulder, towards
you personally do that?
No, I would
You
have
personally do
somebody.
super- okay.
I would delegate somebody to perform suprapubic pressure towards the in the direction that the baby is facing, and then I would perform. I would have the mother. Would have the mother's hips hyperflexed in McRoberts. And then if that does not work, I would proceed with the posterior arm maneuver. I would try to get I would try to grab the fetus's hand or as low down as distal on the limb as I could, and sweep it across the chest, and attempt to deliver the posterior arm. If that does not work, I would attempt rotational maneuvers on the shoulder, either posteriorly or anteriorly. And then I would, if that does not work, I would potentially proceed to using a red rubber catheter or something to hook the axilla, and try to deliver the arm that way. If that doesn't work, I could proceed with fracturing the clavicle, and I would make sure to fracture away from the chest cavity to try to decrease the diameter, the width of the biacrosomial diameter. And then I would perform a Zavanelli's, which would be kind of like my last resort, which is replacing the fetal head by reversing the steps of the cardinal movements of labor, and then proceed to the operating room for delivery through a hysterectomy.
Is there anything else you could do before you do a Zamanelli?
Sometimes Gaskins can increase the anterior posterior diameter of the pelvis.
So what is a Gaskin maneuver?
That's when you have the mother on hands and knees, and that sometimes allows for delivery of.
So she's on hands and knees, and then what do you do?
Instead of delivering, instead of placing downward traction, you would be placing upward traction on the head to assist with delivery of the anterior shoulder. Anything
else you could do that, let's say you have to do a Zamanelli, but is there another technique you could do before doing a Zamanelli?
I don't think this is commonly done, but I mean, I've never seen it, but you could potentially do a symphysiotomy.
So what'd you do? How would you do that?
I think you would have to you would have to fracture the mother's pubic symphysis.
How would you fracture it?
I'm not sure.
What is a Bishop score?
A Bishop score is measuring the is taking into account the cervical readiness for, it's used typically for induction purposes with a score greater than 8, indicating that you are, through an induction, you are just as likely to have a vaginal delivery as if you went into spontaneous labor.
So what are the components of the Bishop score?
The components are cervical dilation, effacement, station, the position, so anterior, mid, or posterior, and the whether it's soft or firm. Sorry, what is that called? Yeah, whether the cervix is soft or firm.
So do you recall this patient's Bishop score?
Not offhand.
So do you remember what induction of labor method was used and why?
Yeah, I don't know her exact Bishop score, but we did start with, because she did not have a favorable cervix, and we decided to initially start with a ripening agent. So we started with Cytotec. After she had adequate cervical dilation, we proceeded with an amniotomy.
What do you mean by adequate cervical dilation?
Usually in my practice, I would have the patient be dilated to about 3 to 4 centimeters, and also have the station be at least -1 in order, -2 to -1 in order for me to perform an artificial rupture of membranes. And then after rupture of membranes, and after the Cytotec was washed out, we proceeded with Pitocin.
So let's say the patient is undergoing a TOLAC. What induction of labor methods are available to that patient?
If the patient were undergoing a TOLAC, she would not be a candidate for Cytotec. So instead, we would ripen her cervix with mechanical method, such as a Foley balloon.
Anything else?
And you can use a Cook catheter. And then she would also be able to have rupture of membranes with Pitocin.
Is there any type of prostaglandin you can give to a patient that's undergoing a TOLAC?
Yeah, I think you just can't give PGE2, but you can give PGE1. So a different type of prostaglandin, I believe you can give.
Are you sure about that?
Yes.
What antibiotics do you use to treat choramnionitis?
We would typically use ampicillin and gentamicin.
And why do you use ampicillin?
For coverage of group B strep and other gram positives, I believe.
And what about gentamicin? Why do you use gentamicin?
Gentamicin maybe for anaerobes.
You're asking it as a question.
I'm not sure. I think for anaerobic coverage.
So let's say this patient's 37 weeks and she has decreased fetal movement. She comes to your office. How would you evaluate her?
I would first elicit a history regarding the fetal movement, when she is measuring the fetal movement, and the typical, typical times that the baby is most active. And then I would proceed to perform an ultrasound to assess for
Is there
fluid.
anything before? Is there anything else you would do before doing an ultrasound?
Oh, I would Doppler for the heart rate.
Right. Anything else you would do?
I would have an NST performed if my office has capability for that.
So let's say the NST is reactive. What would you tell the patient?
If the NST is reactive, I would tell the patient that it is a great tool it has a good negative predictive value for stillbirth or IUFD, and I would be reassured by that and follow her up in clinic in the next week just to make sure that the pregnancy is continuing to go well.
And what is a reactive NST?
A reactive NST is as an NST that has 2 accelerations. If she's greater than 32 weeks, it would be 15 beats per minute over the baseline for a 15-second time frame. So 2 of those accelerations over 20 minutes.
Now, can you have deceleration still have a reactive tracing?
Yes.
So let's say she has a non-reactive tracing. What would you do?
I would try to elicit accelerations by either giving her some juice or something sweet. Sometimes that does elicit accelerations in the fetus, or you can even just give them ice water, I think. And then the other thing you could do is do vibroacoustic stimulation to potentially get an acceleration.
So let's say you don't have a vibroacoustic stimulator. You gave her water. Still, it's a non-reactive tracing. What would you do?
I would perform a BPP if my office has the capability to perform bedside ultrasounds. Yep.
And what would concern you in the biophysical?
If she has a score on the biophysical of 6 or less, that would definitely be concerning, or at least it would require follow-up. Anything else, so if she has an 8 out of 10 because she has a non-reactive NST, I would be reassured, and it would give me reassurance.
Let's say her biophysical is 6 out of 8 for no breathing. What would you do?
I would repeat at what gestation?
37 weeks.
37. I think you deliver if she's term and if the BPP is 6 with a non-reactive NST.
She doesn't want to get delivered. What would you do?
I would counsel her on the risks and benefits of induction at that time versus expectant management with close follow-up. I would discuss that even though the positive predictive value is not necessarily, well, the best use of the BPP and NST are for negative predictive value. We do still have some concern because she is term and does not have a reassurance.
But she's term, but she's early term.
Yeah.
So what can you offer her other than induction?
I could offer her prolonged monitoring in the labor triage area.
What else? She has to go to work. She don't have time for that.
I could offer her a repeat in 24 hours.
A repeat what?
BPP and NST in 24 hours.
Okay, let's stop there. What'd you think?
It was fine, I guess. Some questions were a little hard.
These were pretty basic questions though, right? I think anyway. I think you did a good job with the shoulder dystocia, but don't forget, I don't recall you saying that you would seek help, you would call for help. I didn't hear you say that.
I did say that.
Okay, that anytime you have an emergency in any obstetrical issue, you're calling for help. And remember, as you're doing, because you went, I mean, I didn't have to say anything, you just kept it going, you just kept it going. You always want to go back and repeat things. Okay? You may do the, you know what I'm saying? You may have done the posterior arm, it doesn't work. You're doing the wood screw. Hopefully she's in McRoberts still. Somebody can still be doing suprapubic. Keep trying different things and always go back and redo things. Usually the gasking, you want to do that as you're running to the back and you're literally on the bed with her. You know, so that way you're not wasting time moving her to the back. You're trying, and sometimes that movement of her getting in that position, all that dislodges. The Zambinelli is very, very hard to do. And they make it sound like it's so easy. It's very, very hard. When I did the exam over 10 years ago, symphysiotomy was not even part of the discussion. Apparently now it is more so, because they say it is as catastrophic as the Zambinelli. So you want to make sure you put like something in the urethra. You want to move that urethra out of the way, and with a scalpel you just cut up. And literally, so I know somebody who did it. Literally, you cut that ligament, the symphysis pubic ligament. It just opens up that pelvis, and the baby just falls out. Then the patient has to be like wear a girdle, get banded, because she's gonna, you know, it's gonna be a long recovery, but they usually do recover, to my understanding. I've never seen it, but I know somebody who did it, and it was a 12-pound baby. And that's the only way they got the kid out. So you cut up, not down, because you can damage, of course. And that's just reading it. Never seen it. Never seen it. Induction of labor. To my understanding, no prostaglandin is acceptable in a TOLAC. See, but I asked you certain questions thinking you may not know them because you're an oncologist. They may not ask that question because they're not going to know you're an oncologist. Maybe they'll figure it out. I don't know. Because they don't see the other lists. They only see the list that they're testing. They'll know probably you haven't done that many cases, or you're in some type of fellowship. Am I making sense?
Yeah.
You have your residency cases that they can't see, right? Any questions on that? You were fine with the Bishop score. It is the likelihood of a vaginal delivery similar to spontaneous labor, anything eight or greater. It's medium or soft, firm, consistency. That's the word you were looking for.
Consistency. Okay.
Yeah. Chorio, ampicillin for gram positive, gentamicin for gram negative, clindamycin is for your anaerobes.
Okay.
Okay. I don't know what the right answer is with the decreased fetal movement. Some people would deliver her. Some people will have her come back in 24 hours. She is early term. I said 37 weeks. Because you could have a non-reactive tracing. You could have appropriate variability, but you just are missing that 15 by 50. You're getting 10 by 10s, right? And your biophysical is 6 out of 8 with no breathing. If the fluid is low, that's different. She would have to be delivered. That's, you know, there's no question on that one. But I think you got to take the whole. You do not have to. You can have D cells and have a reactive tracing. So let's say it's just she has good variability, moderate variability. She's 10 by 10 instead of 15 by 15. It's still a reassuring tracing.
Yeah.
6 out of 8, I would have her come back in 24 hours.
Okay. So you don't deliver for early term at
I
6?
wouldn't.
Okay.
I wouldn't, but I think some people would. Now let's change it a little bit. Let's say she's having occasional variables. Would you feel comfortable sending that home?
No.
So I think you got to see what the tracing's showing you.
Okay.
I think. I'm sure an MFM will say something different, but that's what I'm thinking. Maybe we should ask Bobby or something. So other questions?
No.
No, I think you did good for an oncologist. Yeah, you did great. These aren't easy questions.
Thank you.
I know I'd be like, what? I don't even remember how to deliver a baby.
Thanks.
They'll call you for the accretus, you know? Bobby, I'm trying to unmute you. Are you there, Bobby?
Yeah, I'm here.
What do you think? Am I out of turn saying that?
No, I mean, I agree with everything she said, though. I think that most guidelines say you can offer delivery for 6 out of 10 once their term, but repeating in 24 hours is also acceptable. So when she said she would counsel the patient on both options, I thought that was appropriate. Yeah.
You think it's wrong to say just see what the tracing shows?
I think that's also fine too, taking it
Yeah.
all into account. But I don't think you would get dinged for saying that you would offer her an induction at that point.
I always feel like saying it's also how busy is the labor floor today? Right. All righty. Anything else? I mean, I thought her shoulder dystocia was really, really good. But am I correct? Because when I took the exam, you never said symphysiotomy. Now, apparently, that is part of the armamentarium that you could use. Any comments on that?
No, yeah, you wouldn't. I've never even seen that, so not
Not
really.
me either. But that was like a faux pas. You never discussed it. I mean, this is all like, theoretical. You weren't even supposed to bring it up when I took the exam. But apparently they're saying it's just as bad as Alinelli maneuver. So, one is worse for the mom. I mean, both are worse for the mom in the sense that she ends up getting cut, for lack of a better word. But that's much quicker than taking her to the operating room and moving her, prepping her, and all that stuff. Because that you just do it right there in the room, like literally in the delivery room. That's where the guy that I know that did it right there in the delivery room. I was like, oh, wow.
I have a
So,
Can
somebody
I
has a
ask,
question?
can I
I
ask
have
a
a-
question about another
Yep.
case?
Sure.
So I just wanted to clarify for molar, you said that
Mhm.
I know there's no standardized guidance, but you said
Mhm.
for partial follow HCG weekly till it's normal, and then
Times
uh,
3 for 3 weeks. Once it's negative, you follow it for 3 weeks, and then for a month after that, after you get that third negative.
so you follow weekly till undetectable, and then for 3 weeks weekly, and then monthly times 1.
To my understanding.
Okay. It was easier when it was just 6 months.
Right. Again, there's no guidance. So, I mean, but they're saying that, I mean, it's much more riskier with a complete versus a partial. So that's why they're decreasing that. But that's to my understanding. But yeah, 10%, HCG is 10% for molar, 15 for ectopic. That's how I remember it. I'm going to see if anybody has any questions.
Can you repeat what you just said about the ectopic thing?
This is Emily?
No, this is Clarissa.
Clarissa. Okay. Sorry. In regards, so you want to do reliable birth control, HCG weekly until normal for 3 weeks, then monthly if it's a partial mole for 1 month, complete mole for 3 months. However, there's nothing wrong by saying 6 months because again, there's no guidance. But to my understanding, the GYN oncologists, if you read up to date, it says 3 months for complete mole, 1 month for a partial mole. Does that clarify that, Clarissa?
Yeah, and then you said something about an ectopic. Sorry, what were you saying about that?
No. For ectopic pregnancy, everything's a 15% decrease of HCG. While for
Okay.
molar pregnancy, it's 10%.
Okay.
So here is a scenario. If you have an increasing HCG greater than 10% across 3 values over a 2-week period, that could be a concern for GTN, or plateauing HCG for measurements that remain within plus or minus 10% over at least a 3-week period. So both cases meet criteria for postmolar GTN, and you would probably need some treatment at that point and refer to the oncologist. Okay. So you're saying 10% from first blood draw to the blood draw 3 weeks later. You just do sequentially. If it's increasing. You want it to go to 0. It's not going to 0. There's a problem. Does that make it easier to you? I'm gonna see if Chibi's still on the call because we lost her and I want to make sure she got everything kind of in. Are you there, Chibi?